Greetings, dear participants. We are starting the evening of continuous professional education in mental health. This is the project that is being implemented by the Coordination Center of Mental Health of Cabinet Ministers of Ukraine within the All-Ukrainian Program of Mental Health, How Are You? By the initiative of the First Lady, Олена Зеленська. In the nearest an hour and a half, this live broadcast is becoming a place of new knowledge, new instruments, and new practices. The best of the most current and relevant for Ukrainian unique experience that unfortunately so we have to gain. And this is extraordinarily valuable because of the last difficult recent days and nights that are becoming complex weeks and months. There is still a request from you for this knowledge, and we have around 2,000 registered participants, and you're continuing to join to the Zoom platform. And I'd just like to mention that we are also broadcasting on the Facebook page of the Coordination Center of Mental Health of Cabinet Ministers of Ukraine. Right now, we are continuing the topic of PTSD. For the participants who are for the first time here with us, I would like to remind you that in the previous webinars, together with the scientist from Texas University, we've already analyzed the scientifically approved approaches to the treatment of PTSD, modern approaches to treatment, and instruments for diagnosis. And today we will be focusing on the useful and mindfulness-based intervention for trauma and PTSD. Together with us is Entony Kingh. Dr. King, greetings to you, and the head of the psychiatry, PhD, associate professor at the Ohio State University, Department of Psychiatry and Behavioral Health, and director, START Trauma Recovery Center and Resilience Center programs. And so our speaker is the licensed psychologist, psychotherapist, and neurobiologist as well. The research of Dr. King's directed to the studying of neurobiological mechanisms that are as the background of psychotherapy and development of effective and accessible, and what's most important, scientifically based approaches for treatment of disorders connected with PTSD. Dr. King, greetings in Ukraine. Thank you so much for giving us your time, and thank you for being here with us today. And I'm passing you the floor just in a few seconds, because right now I need to voice a few of the miscellaneous issues for our fruitful meeting. We are working in the format 1 hour for a lecture and 30 minutes for Q&A session. Dear participants, you can leave your questions both in the chat, and in the end of our talk, we will be able to voice it for Dr. King to reach exclusive answers for all of you. And the most important part for participants that are right now present from Ukraine, that are in Ukraine, please take care of your safety first. And so if there's an error word, please go into the shelter. If it's going on in your region, please go to shelter. I'd just like to remind you that the recording of this webinar, as all of the previous webinars, you will be able to find throughout the months on the page of the Coordination Center and the Facebook, and also without any time restrictions and any useful time to you or convenient time to you on the YouTube channel. How are you? So have a fruitful and inspired evening to all of us, and it's a great lecture. Dr. King, the floor is yours.
Well, thank you so much. And it is truly an honor to be here with you today and to share whatever little information and wisdom that we've developed over the last 20 years or so. Very happy to do that. And I just also want to express my deep appreciation and respect for all that you do as professionals in helping people, and also both my sadness for the situation, but also my deep respect and admiration for the strength of the Ukrainian people, and very much hoping that the future will soon bring justice and peace. So that is my deep wish. And as was said, I do a lot of work studying neurobiology, using neuroimaging and other measures, EEG. I'm trying to understand how psychotherapies for PTSD work, and also how do we understand the basic underlying problems that happen to people with exposure to trauma and with development of symptoms of PTSD. So I'm not going to talk a lot about that today, because I really want it to be more focused clinically in describing a particular orientation or a particular approach to working with trauma and PTSD symptoms that we call mindfulness-based approaches. I'm going to show you that some of these are effective, but they do have pitfalls, and sort of want to think together about how this approach may be useful. Let's see. I'm trying to advance my slide. Okay, so what I'd like to cover today, it may be a little overly ambitious, but I just want to explain and think together what is mindfulness anyway? It's a buzzword, but what do we mean by that? Specifically, what are mindfulness-based interventions? Why would they be helpful for PTSD and trauma? Sort of some rationale, and then some evidence. I'm not going to spend a lot of time on the evidence, but there's accumulating evidence that MBI stands for mindfulness-based intervention. I think there is evidence that mindfulness-based interventions are helpful for PTSD. Maybe not for everybody, and maybe not in every situation, but there is evidence, accumulating evidence. I will also show you adaptations that I believe really are important for effectively and appropriately using mindfulness in the context of trauma. That may be different than the way that mindfulness is applied for people who have not experienced trauma. And then I'd also would like to practice some of these techniques together. If we have time, I'm sort of going to try to go through the didactic part in about 35 minutes. And so we have about 25 minutes for practice. So I do want to start by saying, of course, that there are really highly efficacious treatments, science-based, empirically supported treatments already available. Prolonged exposure, for example, cognitive processing therapy or CPT, eye movement desensitization, trauma-focused cognitive behavioral therapy. There's a lot of effective treatments. But I also have to note for a large meta-analysis done in the United States and other places, particularly with military veterans, have found that there's some complications to the effectiveness. In particular, avoidance. A lot of patients just don't want to do this. The intensive forms of trauma-focused therapy. Sometimes it's quite arduous, and there's high rates of dropout. And unfortunately, a lot of patients, people with PTSD, retain their diagnosis. So there is work to be done, and I personally believe that multiple approaches and flexible approaches. We say an American sort of idiom is one size does not fit all, and I really believe that we have to really have many different ways to approach that are appropriate for our patients. And also importantly, while trauma-focused treatments, I think there's excellent evidence that they are helpful for the people they're helpful for, there's really the treatment in the context of ongoing threat of repeated exposure is really still an area of active research. And I'm curious of whether mindfulness-based approaches may be helpful for some patients in some of these situations. So let's start with what is a mindfulness-based? What is mindfulness? What do we mean by that? Is it a state? Is it a trait? Is it a process? I believe it's all three. So it's an interesting term. John Kabat-Zinn, who is usually credited with really introducing the idea of mindfulness-based interventions, defined it this way: is that mindfulness is paying attention. There's attentional control in a particular way, on purpose, in the present moment. So present moment awareness and using non-judgmentally, or sort of suspending judgment, trying to go from the bottom up. Now, other researchers have defined it differently. So Ellen Langer, who is a psychologist at Harvard, calls it the simple act of noticing new things. This idea of being in the present, of noticing what is present, and being and noticing as opposed to being sort of in your head in representations. So somewhat more elaborated. I'm not going to read through all of these. I apologize, my slides maybe have a lot of words, but I'll provide the slides so people can read them. But I think it's important to recognize that mindfulness has 2 or 3 or maybe 4 components. But one way of thinking about it is there's a self-regulation of attention. When you do mindfulness practice formally, you maintain an attention on purpose to present moment experience, noticing mental events as well as sensations, mental events meaning thoughts and feelings and sensations, as well as what you might perceive in other channels. And then you also adopt an orientation toward one's experience that's characterized by curiosity, seeing things as if they're new, openness, and acceptance. And that's what I think John Kabat-Zinn means by non-judgmentally. Now, there's a lot of different interventions that use mindfulness-based, or might use the concept of mindfulness. And are they all the same? Are they different? I don't know. I personally think it's kind of all the same, but maybe different ways of getting at these different processes. Certainly in ACT, attention, acceptance and commitment therapy, there's a lot of attention paid to the present, to sort of acceptance as opposed to experiential avoidance. And you're actually now using mindfulness practices, formal practices, in dialectical behavioral therapy, which I also really respect. There's a whole core of mindfulness. And then in mindfulness-based cognitive therapy, of which I personally am an expert and have spent a lot of time both training and getting certified and running mindfulness-based cognitive therapy programs, also uses mindfulness. They're a little bit different in the approach, but I think it's really the same core skill. And so the sort of the quintessential or the prototypical mindfulness-based intervention is called mindfulness-based stress reduction. And this was started by John Kabat-Zinn and Saki Santarelli back in the late 70s. So it's been around for 40, 50 years. And it's been used really for a lot of different indications, chronic pain in particular, stress related to difficult medical conditions, HIV, cancer, hypertension, etc. But the original MBSR excluded people with PTSD or trauma because they really weren't trauma therapists. But what is MBSR? I'm going to go a little bit into some detail of what happens. So they use both formal and informal mindfulness practices. We start with actually a really interesting one called the raisin exercise. I thought about doing that, but I decided not to because it does require a practice. It's really a sensory-based icebreaker where you eat a raisin very slowly. So I have videos of this, which I can share on a webpage if people are interested. There's a number of them. There's something called the body scan, which involves lying down with your eyes closed and moving through the body, attending to sensations. This is a sort of part and parcel of the original mindfulness-based interventions. And I want to say straight away, this can be very challenging for people with trauma. And so I do use it, but I use it in a particular way. Oh, and I wanted to actually mention too, mindfulness, as I described, what is mindfulness? What is mindfulness practice? I hope it was apparent that this is not necessarily easy. This actually takes a lot of effort. And for people who don't have trauma and who don't have PTSD symptoms, it can be quite challenging. So it's a fair question. Well, why would we even think that doing something so mentally, using so much mental energy would be helpful for PTSD when it's so hard? And I do believe that there's a good rationale. I'm going to share that in a minute. But in addition, we do things like mindful movement, such as yoga or qigong. When I started at the Ann Arbor VA, the Veterans Administration Hospital, 20 years ago, yoga was something usually that the men's girlfriends or wives did. Men didn't do yoga. But now, I don't know what it's like in Ukraine, but yoga, everybody does yoga. Everybody appreciates that. So I introduced the idea of using qigong or internal kung fu exercises. Also sitting mindfulness with different various objects, the body, the breath, sounds, emotional states, and thoughts. And mindfulness-based cognitive therapy is sort of an adaptation of that. So this is developed by Zindel Siegel and Mark Williams and John Teasdale. And the idea behind this was to take the core practices of mindfulness-based stress reduction and apply them to depression, and particularly preventing depression relapse. And I don't have time to show you all the data, but it's actually really effective for helping people who've been depressed. We know that depression is chronic. People tend to relapse over and over again. And mindfulness-based cognitive therapy, which is an 8-session intervention, is done in a group, so therefore it's kind of efficient. It's very effective for reducing depression relapse. And it prevents relapse. It's also engaging, which I think is important. People tend to like it as opposed to more challenging forms of therapy. And so what happens in an MBSR or MBCT class? Well, there's formal meditations, things like the body scan, sitting, walking meditation, yoga or qigong, and something which I'm going to share called the 3-minute breathing space, which is a very brief and portable mindfulness exercise. And then there's what we call informal practice. It's sort of trying to integrate this attitude, practice, this skill of mindfulness into your daily life. And this involves a number of different practices. There's also, we do something called mindful inquiry, which is a particular form of processing during the group. So we do a mindfulness exercise together, and then we talk about it in a particular way, helping people to bring awareness to their experiences and to verbalize their experiences, as well as other forms of group process and integration, and so actually some explicit cognitive therapy exercises. And so I've been spending, well, actually since 2005, so about 20 years now, trying to adapt, or finding ways to see, first of all, if mindfulness-based cognitive therapy is feasible and acceptable for people with trauma and PTSD, and then how to adapt it to make it the best, the most acceptable and the most feasible, and have the best efficacy. So a typical, there's 8 sessions. They all kind of have the same format. We usually gather together and sit and do some silent work to begin with. We do a formal mindfulness together exercise. This can be 20 to 25 minutes. We then do about 20 to 25 minutes what we call mindful inquiry, talking about their experiences, as well as a home practice review. What happened over the last week? Then take a 5-minute break. And then there's usually there's 8 different didactic focuses for that particular week. And we do some discussion, and we end with another formal practice. Now, importantly for people with trauma, as I said, mindfulness practices, or even just sitting in silence, even closing your eyes, bringing attention to the body, these can all be highly provocative. They can really evoke difficult memories for various reasons. Many people with trauma naturally adopt kind of an avoidant strategy. Just keep my mind busy all the time, never slow down, and there I kind of run from the thoughts. And what can happen is the memory, when you invite them, even for 5 minutes, to close the eyes and to just attend to what's happening in the present, it is possible that trauma memories will emerge. I'm not saying that's bad. I'm saying that is what happens. It can be used therapeutically, but people who are doing mindfulness exercises with people with PTSD and trauma have to be prepared for this, have to recognize this, and have to explain this in advance. That's what I found out. It's really important to let people. Also, we train people in what's called the window of tolerance. This is adapted from Pat Ogden's work with sensory motor work, but it's also widely used in polyvagal theory types of interventions and sensory motor, sensory experiencing. There's an idea that we kind of have a window of learning or a window of tolerance, this state of arousal. It's not too aroused and it's not too shut down. It's kind of just right, in which we can safely be with and explore experiences where we can learn. It might be uncomfortable. It might even be uncomfortable and unpleasant, but it's not overwhelming. In this case, we're able to learn and take in new information. So we talk about that when we show people sort of markers of what constitutes the window of tolerance, and then importantly, how to recognize when you're outside, when you're moving in, when you're hyper aroused, moving into the fight or flight mode, and experience the urge to flee or leave immediately or overwhelm. Also, when you're shutting down. Neither of these states are really conducive. They can be useful for exposure, but for learning, for other forms of learning, maybe not so helpful. And so we start with that, with first of all explaining that some of the exercises can be challenging, that they can induce hyperarousal or shutdown. And we invite people to actually, using very invitational language, to actually care for themselves. If you do notice this, it's perfectly fine. I always start by saying everything that's going to be done here is optional, including staying in the class. You don't have to do anything I tell you to just because I say it. And so I always use what we call invitational language. I would like to invite you to sit down, but you can also stand. I usually don't do the body scan now. In the first session, we do a sitting body scan. So a posture is optional. Opening or closing the eyes is optional. Staying in the room is optional. Where you place your attention is optional. But kind of paradoxically, I say, so I want to be very clear what we're going to do today, how we're going to do it, why we're doing it, and you don't have to do it. But if you want to try, I'll invite you. So let's do a brief. This is called the 3-minute breathing space. So it takes 3 minutes. I want to take 3 minutes. And I'd like to invite you to start by stopping. So I've been talking, you've been listening, I appreciate that. I'd like to invite you to stop whatever the mental activity and close your eyes if that's available to you or if that's comfortable, but keeping them open if you prefer. And for the interpreter, keep your eyes open because here's what I'm going to say. So I'd like to invite you to bring yourself into the present moment by deliberately, on purpose, adopting an erect and dignified posture. And if possible, close your eyes and notice, what is my experience right now? What are the feelings I have, the sensations, the physical sensations? What are the thoughts? What are the emotions? So I invite you just to acknowledge these as if for the first time you're noticing that. You're sort of letting everything else go and just bringing awareness to the present moment. And we invite people to do that for about a minute. For the second minute, for the second step, I'd like to invite you now to purposely bring your awareness gently, with full attention to the process of the breath. So noticing as you breathe in, noticing as you breathe out. And we'll just do this for about a minute or a little bit more than a minute. No need to change or control the breath. Simply noticing, this might be 6 or 7 or 8 breaths. But keeping the attention focused narrowly on the breath for a minute. And then I invite you to expand. Again, bring the attention into all parts of the body, noticing your fingertips, noticing your toes, noticing your ears, the feeling of the air on your face, expanding your awareness to include your body as a whole, your posture. Also noticing maybe the sounds in the room, wherever you're at. Even if your eyes are closed, you might notice a certain amount of light as you can register that. And then when it feels comfortable, opening the eyes. And again, maybe looking around your room, in addition to the monitor, the sort of the glowing rectangle in front of you, to reorient to where you're at. And this is called the 3-minute breathing space. This is one of the core exercises within mindfulness-based cognitive therapy, and one that I personally like a lot. It's also used in something called mindfulness-based relapse prevention, which is used for alcohol and substance use dependence, for preventing relapse. When people have kind of detoxified or become abstinent or acutely, and to try to maintain that. So I'm not going to talk about that, but it's also a really interesting and powerful program. There they call it sober breathing, because in English, stop and observe, S-O, is step number 1. Breathe is step number 2. And then expand and resume is step number 3. So if in English that spells S-O-B-E-R, so it's kind of cute. So the breathing space provides a way also to step out of the automatic pilot. And I didn't introduce that term. This is a term that's really also pretty core to the idea of mindfulness-based interventions, sort of the opposite of mindfulness. If mindfulness is being present, being curious, being aware, and in the present moment, and trying to, with curiosity and not judgment, automatic pilot is the opposite of that. It's like, we often ask, have you ever driven someplace and then you get there and you wonder, wow, I don't remember anything about that trip. I was sort of automatically on pilot. We live much of our lives, and actually there's research to this that suggests that we spend a lot of our lives in mind wandering, in our head, in the future, in the past. Now, there's adaptive things to that. That's not necessarily bad. This is helpful for creativity, for memory, for learning. But when you've experienced trauma and you have symptoms of PTSD, very often where the mind slips to is an intrusive traumatic memory. And this is one of the core features of trauma and PTSD. So this is why, one of the reasons I think that mindfulness is helpful. Oh, so we'll do this at the end. But in Mindful Inquirer, we ask people, what did you notice when you did that exercise? Specifically focusing on physical sensations, trying to put into words what you experienced, and then ask, well, how was this different than your normal experience? Or was it different? Did you notice anything different about this? And then the third level of mindful inquiry is, well, how might this be useful? What is this useful? Do you think it might be useful? How might it be useful? So this is sort of what we call mindful inquiry, which we always do after each mindfulness exercise. So, okay, so a bit of rationale. Why would mindfulness-based interventions be helpful for PTSD? So I've sketched out, some of the core symptoms or clusters of PTSD, and we know that imaginal exposure, trauma, therapeutic trauma exposure, and other forms of cognitive behavior can be helpful for the failure of extinction recall, for example, for cue generalization. We also know that imaginal exposure and in vivo exposure can be really helpful for avoidance. And I worked, in addition to the PTSD clinic, I worked in an anxiety clinic for a number of years, and it's really a lot of the therapy is about avoidance and exposure, getting out there. So we know that this is helpful for PTSD. We know that cognitive processing therapy can also really help with cognitive restructuring, sort of working with negative thoughts, how they influence us. And of course, hypervigilance, a number of things, actually exposure can help, but also relaxation can help. These are non sort of other forms, which are empirically supported and work very well. I'm going to argue that mindfulness-based cognitive therapy and relaxation can help all of these as well. Maybe in the same way, maybe in different ways. This is a subject of my research. So hypervigilance for sure, avoidance for sure, emotional negativity, I also believe so. And to some extent, it's active research of whether mindfulness will be helpful for cue generalization and maybe even extinction recall. So other ways of looking at this, so the meta-awareness of emotions can really help with kind of processing and understanding, why am I doing it? How is the trauma memory affecting me? Similar to what's happening in cognitive processing therapy. Also, adapting the openness and non-judgmental present moment awareness can be helpful for avoidance. The grounding that occurs in mindfulness, I believe, and I think that some colleagues of mine, Nagar Fani and Greg Siegel at Pittsburgh and Emory, they're doing a lot of work right now with dissociation, and they're finding that mindfulness is really helpful for dissociation. Actually, relaxation. I'm going to say mindfulness is not the same as relaxation, but it does also, and some other ancillary things like positive emotion savoring, loving kindness, and self-compassion, which are kind of on the periphery of mindfulness-based interventions, I also believe are very helpful. There's a fantastic review, it's several years old now, by Boyd and Ruth Lanius in Canada. I recommend. It's got a little QR code. And she similarly thinks of it the same way. Intrusive symptoms, avoidance. There's different ways that mindfulness-based approaches can be helpful for these core symptoms of PTSD, maybe in the same way as cognitive processing therapy, maybe a different way. We don't really know, but I'm very interested in that. So I do want to say that mindfulness is not just relaxation. Relaxation is actually really helpful, but mindfulness, I believe, is something a little different. And you could even say that mindfulness is a kind of exposure. Not the same as a trauma exposure, where you get a narrative, but really exposure to the extemporaneous content of one's mind right this moment. And it might be a trauma memory. The idea is whatever arises in these next 15 minutes, I'm going to make an effort to sit with it. I might be crying, I might be fearful, I might have the desire to get out of there, but I'm going to make an effort to sit with that. That's brave, and that is a form of exposure. Observing patterns of avoidance, having an attitude of curiosity and acceptance, using mindful awareness as sort of a way of bottom-up processing. There's also active research in Texas that Tanya Nicholson, who I hope was on this line, and Israel Lieberzahn have done a lot of work with the idea of contextual processing. And I really believe that mindfulness can help one understand and better be able to see the context for what it is, as opposed to going into a pattern completion of pattern differentiation to notice where you're at using bottom-up processing. A lot of technical things there, but this is sort of my specific interest. I suck it. That was my timer. My duck. I'm about 30 minutes through, so I got another 5 minutes. So just recognizing relaxation is good. I'm not saying relaxation, there's anything wrong with it. I think it can be very helpful. and is actually one of the most studied interventions for PTSD, although it's usually considered the inert control. But is mindfulness the same? I'm going to say it's not. Relaxation has a specific goal. Its goal is to induce a relaxed, parasympathetic physiological state, changing and specifically reducing aroused states. And frankly, it can be misused. People can use this in a very avoidant way. It could also be properly used, but you have to be careful on how you apply relaxation for people with trauma. Mindfulness, as I've been explaining and thinking together with you, it involves bringing active awareness to the present moment and observing sensations, feelings, thoughts as they exist right now, not trying to change them, not paradoxically, not trying to attain any particular state, but in a way kind of exposing oneself to that and finding some acceptance. How can I kind of live within this adaptively? Now, I also want to point out that mindfulness can also be misused as avoidance. So it's important to recognize this in the same way that subtle avoidance behaviors are also present in things like other forms of exposure, in vivo exposure, in panic or in OCD. So being aware of that. Are mindfulness-based interventions helpful? I'm going to speed through a little bit of this, but there's a lot of literature on this. I just wrote a review paper, which I shared. I think they are. This is actually not PTSD. This is for mindfulness-based cognitive therapy for depression relapse. There's a pretty large effect size. It decreases relapse by like 30%, and it's actually more effective than continuous antidepressant medication, which is really interesting. This type of learning helps people stay not depressed. And here's what's important for trauma. It helps the most. So you see that on the bottom, the y-axis is the relative risk for depression relapse. Well, relative risk is usually the number of previous depressive episodes and things like trauma exposure, childhood trauma, childhood maltreatment. And this is where we see the people who have the highest levels of trauma and also have the highest levels of efficacy of mindfulness-based cognitive therapy for depression. So it's not a direct indicator of PTSD, but it certainly, there's been a lot of work over the last 10 years looking at mindfulness-based cognitive therapy interventions for active depression, so for suicidal depression. So this can be done with people with severe and life-threatening conditions like suicidal depression safely. This is work that I published back in 2013 at the Ann Arbor VA. This was actually working with veterans, military veterans with PTSD, chronic. Actually, one of the oldest veterans in there was in the Korean War. There are a lot of Vietnam vets, also American veterans who had served in Somalia and Kosovo. And we did see, interestingly, it was mainly in this study in the avoidance symptoms, but we saw overall about a 17-point decrease in PTSD symptoms among this population who had been symptomatic for 30 years. So we really thought that was meaningful. It was small study. So we followed that up with actually, I'm not going to get into what mindfulness-based exposure therapy is. We developed a new intervention that combined mindfulness-based cognitive therapy with in vivo exposure, no trauma exposure, but with in vivo exposure. And we actually also found about a 20-point decrease in PTSD symptoms. And this was an effect size of Cohen's D, or actually Hedges G, of 0.9. So this is not bad. This is sort of, prolonged exposure in intent to treat is usually closer to 1.5, but 0.9 is respectable and a large effect size. So I'm not going to go through all the data. There are some early studies, and I also want to point out this really excellent recent umbrella review of looking at mindfulness-based interventions. So the QR codes are there. I'll point, there's been about 89 clinical trials of mindfulness-based interventions. The quality is really variable. Some of them are good, some of them are not good. But there's also about 65 systematic reviews. So there's almost as many, so there's like 80 or so reviews and meta-analysis. And there's only 80, and there's 89 clinical trials. So there's been a lot of interest, but we need more data, I would say. The effect size found in this umbrella analysis was not large. It was a medium effect size. And the conclusions of that study was that MBIs are really not first-line PTSD treatments, but they may be helpful as adjunctive treatments and for particular patient subsets. We also know already that EMDR, prolonged exposure, has a high dropout rate, high refusal rate, And so therefore, MBIs may be particularly helpful for people who don't want to do trauma-focused therapy or have other indicators of risk or other problems or drop out. But I also want to point out that actually certain populations appear to benefit more, and in particular, military veterans. Now, again, the quality of the data is variable, but there's consistent, the effect sizes has ranged from 0.4 to 1.2 in military veterans. It's considered a large effect that's on par with trauma-focused treatments. Mindfulness-based cognitive therapy, similarly, it's a very similar intervention, but also from 0.1 to 0.9, and in randomized controlled trials or other forms of clinical trials. Something called mindfulness-based exposure therapy, which I showed that was something that I developed, is also not bad. Mindfulness-based relapse prevention and mindfulness-oriented recovery enhancement are 2 8-week mindfulness-based interventions really focusing on pain and substance use problems, which are very often very comorbid with PTSD. And they're really not focused on PTSD as a primary outcome, but they have published secondary outcomes, and they do appear to be helpful for PTSD. So I think overall, mindfulness-based interventions can be helpful for PTSD if they're done with appropriate care and attending to those particular needs of patients with trauma exposure and PTSD. So I've published back in almost 10 years ago, some principles for adapting. This is a chapter which I shared. I'm happy to make that available for how to adapt mindfulness-based cognitive therapy for combat PTSD. And really, as I spoke about using invitational language and egalitarian stance, really attending to safety and perception of safety, making sure the doors are locked, making sure not turning off the lights, for example, keeping the lights on, and inviting people to keep their eyes open or sit how they like to, telling them you don't have to do what I tell you. It sounds obvious, but it's really important, I believe. Also, this is a joke. I use the R word. The R word is relaxation. A lot of people who do mindfulness really stress how it's not relaxation. It's something different. Well, relaxation is also good. and in fact, with the military veterans in particular I've worked with, about 95% of the time, they think what they're doing at first, they want to do relaxation. They say, what are we, and I totally explain what mindfulness is. They say, oh yeah, that's going to help me, balance my nervous system and get to a calm state. And technically, I think it's a little bit different. So we start with relaxation. We meet them where they're at and actually find ways to soothe the nervous system by slow breathing, something called box breathing, and actually noticing how they feel after doing a mindfulness exercise. There's very often relaxation occurs. We're also talking about noticing the body and the emotions and the sensations, noticing the window of tolerance. Importantly, you have to be prepared for upsetting reactions to sitting quietly. And I experienced that a number of times. Not every group, interestingly. That was the fears. It was going to really lead to sort of deepened rumination or some experiencing symptoms. They do come up, and sometimes people become tearful or upset or angry. And the important thing is to be, that's why I believe that mindfulness-based interventions should be led only by people who are experienced trauma therapists, who can recognize the territory and be able to respond appropriately and to try to use these reactions as grist for the therapeutic mill, as therapeutic exposures instead of just distress. Shorter exercises. I never do. John Kabat-Zinn always did 45-minute mindfulness exercises. I never do. I do 20 minutes. Body scan. So also be taking a lot of care with the body scan. We set it up and we explain and scaffold, so to speak, why are we doing this? How are we doing this? Give choices, psychoeducation, etc. Trish Magyari and my late friend, Lisa Kimbrough, who are just fantastic, really, really respect their work a lot. They work mainly with women who've experienced intimate partner violence and sexual abuse, also very traumatizing conditions, and also a lot of PTSD. Very similar. So we thought together. So we published this independently, and then I started spending time with Trish because I really appreciate her work. Giving control through options and choices, teaching ways to self-soothe and use the window of tolerance. So she kind of reintroduced me. I knew about the window of tolerance. I wasn't using it. So she expressed the importance of that. Orienting to time, space, grounding, downregulating the nervous system before we start to do the more challenging forms of mindfulness exercises. Also limiting silence. Silence can be very evocative and provocative of PTSD and trauma symptoms. So the idea at first, especially, first several sessions, fill that space kindly. Use a kind tone of voice. Use an egalitarian stance. And increasing the structure of the class and letting people know what's happening. There's also a wonderful book by David Trelevin, coming after our papers, but it's called Trauma-Sensitive Mindfulness, and very similarly. So you focus on the window of tolerance, focus on stabilization and safety, recognizing that people can dissociate and that we don't often know it. We have to really pay attention and check in with people because they might be dissociating, they might be having trauma, intrusive memories, and not saying anything. So checking in, practicing in relationship, and importantly, understanding social context, power differentials, historical trauma, etc. So these are some things. Window of tolerance we talked about. I'm going to skip through this a little bit. And actually, time, we have about 17 minutes. So these are some more specifics on that. I'll share the slides. And let's see what's the most important one. Talking to people, I think it's also important to talk to people and explain what the mindfulness group is or what they'll be doing before kind of throwing them in. I also don't recommend, as I said, sending people to go to a meditation or even a yoga class, which is taught in the community by somebody who's not a therapist. These are evocative types of exercises. They can be therapeutic, but in the same way that you wouldn't necessarily send somebody to do prolonged exposure with somebody who's not trained in prolonged exposure. Similarly, mindfulness should be done with trauma therapists. Teacher characteristics, obviously gentle, sensitive, clear boundaries, empowering, etc. This is we can answer this question. This is a conceptual model that Zindel Siegel proposed about 20 years ago, which I still think is a very good model, and some details. This actually, I'm not going to talk about this at all. It's for 30 seconds, but this is my research looking at how mindfulness-based therapies affect the brain, affect the default mode nervous system and connections between the default mode and the salience and the default mode and the dorsolateral prefrontal cortex. This is sort of attentional or executive control. What's interesting about this is I'm not the only one who's found it. So Judd Brewer at Yale, David Cresswell at Carnegie Mellon, Tommy Crowell at Wisconsin, and another group at Pitt have seen similar things. So it may be a reliable signal that mindfulness practice over 8 to 10 weeks may actually be doing something to the way that the brain is connected. Okay. Well, I would like to practice together. We have about 15 minutes, some mindfulness exercises. And these are directly from mindfulness-based cognitive therapy or from our adaptation. And the first one I'd like to do is stand up. Okay, that's what we call mindful movement. And if you want, you could also remain seated if you choose. Stand the posture, the physical part of it is not that important. What is important is the mental part and noticing sensations. So if you're standing up, and if like me, you don't have shoes or socks on, which is the best way to do it, I invite you to really feel your feet. And if you are wearing shoes and socks, feel your feet. Notice what your toes can feel. Notice what your heels can feel. Notice what happened when you start closing your eyes, if that's available and appropriate for you, keeping them open if you prefer. But closing the eyes helps bring attention to our internal experiences. And that's what mindfulness is. Bringing attention to your internal experiences and recognizing them as internal experiences, mental events in the present moment. And also being curious about them, maybe noticing your knees, noticing that when you're standing, it's kind of interesting. We say standing still. I don't know in Ukrainian if this is the same thing, but I'm not standing still. I'm moving a little bit. There's a bit of shifting of weight from the left to the right, the front to the back. There's muscle. It's a very active thing to stand still. There's muscle groups contracting. There's proprioception. There's all sorts of things are happening. I'm noticing where I'm at in time and space. It's an incredibly active, incredibly rich experience. Mindfulness is bringing awareness to that. as opposed, really being present with the complexity of what's happening in the present moment. So in mindfulness-based cognitive therapy, there's often some movement from hatha yoga, bringing the arms over the head, for example, bringing the arms out straight. Well, a lot of things. I can share some descriptions of that. What I want it to be experiential. Try a couple different things. So I invite you now to, in a purposeful way and manner, noticing your movements, come back to your seat and then notice what happens. Notice how it's different or the same as you sit in a chair. Noticing maybe where your feet are making contact with the floor. Noticing the muscles that are keeping your body upright. And John Kabat-Zinn again uses language that I like a lot, very beautiful language. He says, adopt a position, a posture that embodies dignity and awareness. Having respect for yourself, having dignity and moving awareness into the present moment. And if you like the 3-minute breathing space, we can also do together now that we're seated. Step number 1, stop and observe. Again, bringing awareness to the sensory channel. Our minds have a lot of different channels. There's the feeling channel, there's the emotional channel, there's the thinking channel, there's the hearing channel, the visual channel. So closing the eyes to kind of shut down the visual channel and to help to allow awareness to the other channels. In particular, the physical sensations, noticing the toes, noticing the back, noticing the body as a whole. And as you bring awareness to the body, you may become aware of the rhythmic process of the breath, that every few seconds that air is coming in through your nostrils, filling the lungs, gently expanding the chest and abdomen. As you breathe out, there are also a series of sensations and movements. So continue that attention, that curious movement of your attention to the breath, kind of tightly focused on the breath for 1 minute, maybe 6 breaths. This is called breathe. And then for the next minute, I invite you then to expand your awareness out again, moving out from the breath, also noticing the toes, noticing the fingers, noticing the back of your neck, noticing the muscles and bones where you're sitting and making contact with the chair and the floor. Bringing awareness out into the room, noticing the sounds around you. Both my voice, but also there's other sounds most likely of maybe the air conditioner, ventilation, or traffic. And then I invite you to slowly and gently open your eyes and attend to the colors and contours of what's around you. Again, maybe taking a look around, reminding yourself, where am I at right now? So this is sort of an example, a brief example of mindful movement and the 3-minute breathing space again. Now in mindful inquiry, it may be difficult to sort of do a conversation. So what I'd like to invite people to do, if you'd like, is sort of write down or just make a mental note. What did you notice during this exercise we just did? Please describe the experience, focusing on the physical sensations, what you physically noticed, as well as any thoughts and emotions, but kind of keeping them, giving them all equal weight. Very often our thoughts maybe take greatest importance. Everything else gets squished out. Here we want to appreciate the sensations, appreciate the emotions, and acknowledge and appreciate the thoughts. How is this different than when you might normally sit in a chair for 3 minutes not doing anything, or sit in a chair listening to a lecture or doing work? How is this different, if it was? And then also, how might this be helpful for people struggling, people with stress, with depression, or with trauma and PTSD? And we can, maybe I'll ask people who wish to share their experiences during the question and answer. I have 8 minutes of didactics. I'm going to take it. Experience. Oops. Now this is an exercise called the arriving practice. This is not mine. This is from Trish Magyari, who I deeply respect, and are really clever. So I'd like to invite us all. Maybe let's stand up again. If you want to, just kind of shake out, shake your arms and legs, and come and take a seated position again. We spend a lot of time, at least I do. I'm not sure what everybody does. I tend to spend about 3/4 of my time sitting, whether I'm doing therapy or whether I'm doing research. So I try to force myself to get up, every hour and do something. The arriving practice is very beautiful, and it's specifically adapted for people with trauma and PTSD. So start by orienting to time and space. Today, it's about 8 o'clock in Ukraine, I believe. Noticing, maybe thinking, just making a mental note of where you are in the room. What room are you in? What building are you in? What house are you in? What's the address? Orient yourself to the here and now. As Ram Dass or Richard Alpert used to say, be here now. And this is about being here now, orienting. And then noticing, going in addition to sort of where I'm at and noticing what are the sensations like as I'm sitting here. What are the points where my body is touching the room? Maybe it's touching the floor, the chair, maybe you're standing, or sort of noticing that, bringing awareness to these points of contact, helping to literally ground. And now also, in addition to our connection to the room, with your eyes closed if that's comfortable, but also keeping them open if you prefer, noticing silence. How are we oriented in the space around us? What do we notice? What external stimuli are coming in? Moment by moment by moment, noticing. And now this is what Trish calls and others call the mindful sigh, S-I-G-H. This is a way to induce and increase parasympathetic tone by breathing out, having a long exhale, and making a sighing sound like a breathing in. So the long exhale, there's also something called 3-7-4. I would mix up the numbers, but having a longer exhale than an inhale tends to activate the vagus nerve and the parasympathetic. So working with trauma, we can use specific relaxation and parasympathetic sort of balancing of the nervous system in a skillful way that works together with mindful awareness, helps to bring people into the window of tolerance, the zone of learning. And after we've done that, again, noticing touch points, hands, soles of feet, noticing underneath your seat, what do you notice there? And then we can, so normally when I do the arriving practice, it's about 20 minutes. So I'm really condensing it into about 3 minutes. But then the invitation is to move into the breath again, recognizing that breath can be activating, it can be provocative, particularly the core of the body and the pelvis can be bringing attention to these areas can be very provocative of symptoms. So being aware of that, that's where we don't come to the breath. This is what Trish does in every first session, actually before doing the raisin exercise. And I really like it, so I've incorporated it into my work as well. And then we can move into the body and traditional. So, and then if we like, notice emotion. What emotion do you feel right now, if any? And some people always say, I don't feel any emotion. Okay, that is what the emotion you're feeling, none. The emotional tone is neutral. But also noticing if there may be slight forms of agitation, of worry, of irritation, of hunger, longing, whatever it might be. Kind of noticing that with a curiosity. We're not needing to do anything to fix it, but it's really the awareness. And again, if you like, noticing what did you notice, or writing down what did you notice, describing experiences, how was this different, how might it be useful? We don't have time, we have about 2 minutes, so I'm just going to describe this exercise. And I'd like you to try it at home if you like. It's called mindfulness of a nourishing memory. So the idea is you would close your eyes and remember a time. Recent time if possible, that's very helpful, but maybe not, maybe something, 10, 20 years ago, where you felt connected. You felt happy. You noticed the corners of your mouth just naturally tend to rise. You feel a lightness in your face. You feel love or compassion or connection. And as you do this, this is from something called metta meditation, sort of a Buddhist type of meditation, but it's also a positive psychology. It can also be called savoring. Noticing sometimes they really experienced this feeling of particularly connection, of interpersonal connection, and then move into that feeling in the body. Where are you feeling that? Is it in your chest, in your belly, in your face, in your shoulders? And stay with that, refreshing the memory every so often. So now attending to sensations first, being curious about sensations, as well as emotions, attitudes, and thoughts. And the last one, which I don't have time to go, literally 1 minute. This is a bit challenging, actually. This is part of mindfulness-based cognitive therapy, but for trauma-exposed populations, you have to be careful with this. You have to explain it very well. Because what we don't want to do is have people remember their trauma or traumas, recognizing, of course, that, I use the clinician-administered PTSD scale quite a bit because it's considered a gold standard. And a lot of time you spend focusing on the index trauma as though there's one trauma. Some people have one trauma in their life. In a sense, they may be, I don't want to say lucky, but most people that I've worked with clinically, there's not one trauma. There's a lot of traumas. And so the idea with this exercise, we want to try to focus on a difficulty, an unpleasant event, an irritant that is small. And I sometimes use a 1 pound weight rather than a 100-pound weight, or we can use kilograms, the metric symbol. Only the United States uses pounds for some reason. But think of a 2 kilogram weight, not a 100 kilogram weight, not a trauma, but an irritant. Like maybe when your PTSD symptoms got in the way, or maybe when somebody ticked you off, or you had to wait, you experienced some road rage, well, that can be dangerous as well. But try to keep it minor irritant. And then also notice, well, okay, not try to fix it. It's important. Stay with that irritant for a while. Close your eyes, and to the extent you are able to safely, move into it. Be curious about it. What do you notice? What do you feel in the body? First, really trying to get a handle on the feelings without trying to change it. What are the emotions and what are the thoughts? And then we sit with that for about 10 minutes. So again, it can be provocative, but a lot of people I work with say that they find this really, really helpful, and they're willing to do it. So again, I'm very honored to have this opportunity to speak with you today, to share little things that we found are helpful, and I'm really eager to have some conversation as well. I guess I'll stop sharing my slides. How do I do that? There.
Дякуємо, доктор Кінг.
Oh, thank you so much, Dr. King. Thank you so much for such a going in depth for this 3-minute breathing space and for all of the practices. We are collecting in the chat the feedback from our participants, both in mind and the body. There's like lightness and relaxation that appeared, and we are hopeful that our wonderful interpreter and everybody else who will be watching us in the recording will be also able to fulfill those practices as well. Okay, apart from the words of gratitude, which is a lot of that in the chat, we do have a question from our participants, from Inna Moroz. If a patient with the PTSD, because of the constant anxiety or dissociation, doesn't feel their body, they don't, during body scan, they can't feel anything. Like, what can you do in such cases, and how can you use mindfulness in such cases?
That is I really appreciate that question. And it happens, it does happen. I've experienced it. So I'm going to tell you a couple different ways that I tend to work with it. One, for example, very often many people, whether they have trauma or not, can't feel their toes. When they move their attention, they just don't feel anything. And so the idea of normalizing that is their experience. Again, a lot of mindfulness is paradoxically not trying to change things. Of course, as therapists and as human beings, when we have distressing experiences, we want to change them. We don't like them. Mindfulness is ironically, in some ways, maybe paradoxically, first noticing what is there and acknowledging, not saying accept, but acknowledge that I bring my focus to my toes and I don't feel anything. My experience was I didn't feel anything. Okay. That can be frustrating though. So I use that sparingly. I sort of introduce that, but then use the hand. Put a hand on your belly, for example, as you're breathing. Put a hand on your heart. Put a hand places. And this is not standard mindfulness practice, or doing gentle movement. A lot of times in yoga, Hatha yoga, also in Raja yoga, uses savasana and uses a body scan, which is very similar. But very often what they do is introduce a little bit of movement and then invite that area to relax. So it becomes a body-wise relaxation process. That's not the way it's done in standard mindfulness, but I will sometimes do that. And particularly, and I would even say, if you don't notice anything, if you want, introduce a little bit of movement. That's the second way. The third way is what my colleagues Nagar Fani and Greg Siegel are doing, which I think is really super cool. They actually, because people can't feel the body, they dissociate. They can't feel the breathing. It's difficult. So they actually have something called a subwoofer. It's a speaker which they strap on, which they're available commercially. They strap this thing onto people's chest, and it vibrates. So when they breathe in, they get an exteroception. So we talk a lot in mindfulness about interoception, noticing within our body. But for people with dissociation, very often interoception is not available. And so we use exteroception, and in this case with a device. Now the devices may not be, they're expensive and things. So, but that's really cool. So they're doing an ongoing research project right now using the woofer to create a vibration which can help people attend to the body. So, but I would say in clinical practice, movement, move the toes a little bit, and using a hand on the belly, hand on the chest, even a hand on the face, and also the body scan, as I said, is a challenging exercise. And so often, well, actually, now our standard practice with PTSD is to start with the arriving practice to do a form of body scan which is seated as opposed to lying down, and invite people to try it lying down at home. I don't know. Did that answer the question well enough?
Hopefully so, because there was a question in the chat that the person can write into the chat. Thank you so much. And so the next question is from Katerina. Is there any contraindication to the useful mindfulness techniques? And if there's any, then what are they?
Yeah. So yes, there are. And I think they're kind of similar to challenges that occur in exposure-based therapies as well. So childhood maltreatment, in particular, this is I say it's somewhat ironic because the one hand, mindfulness-based cognitive therapy for depression is the most effective, or at least it shows the biggest treatment response with people with childhood maltreatment. But I also would say people with childhood maltreatment, and particularly sexual abuse as a child, the body scan in particular is very provocative. And so I would want to screen, to talk with people about their experiences and about their sensitivity, and maybe ask them, so I definitely think having a one-on-one, so one of the advantages of mindfulness-based interventions is that they can be done in a group. So they're efficient, and people really, and very often, not everybody, but many people really like the group experience. But I would urge everybody to, talk one-on-one first. Ask about childhood experiences. Ask about sexual abuse and assault. Ask about sensitivity. What do they notice when they focus on their body? Maybe even doing a brief, 3-minute breathing space and seeing how they react. So I don't have categorical exclusion factors. Well, I do. So for my studies, we don't take people who have a lifetime history of psychosis, although it's not necessarily clinically. I do work with people with psychotic disorders, early psychosis, but for the studies, so I would say it's more on a one-on-one, case by case. But I think explaining what's going to happen very well, giving people options, let them know they don't have to do it. If they don't find this comfortable, you don't have to do this. I mean, it sounds obvious, but as we know, patients with trauma are looking for help, and and as respected therapists, they'll try to do what we tell them. So it's an important question. I don't have 100% answer for it in terms of like a broad, a categorical answer for counterindications, but I'd say it's more case by case.
Дякуємо.
Oh, thank you so much. So we are moving to the next question. So how can we use this technique? So we are speaking mindfulness mostly to use with children. Can you use it with children? And if yes, how?
So there's been a lot of work done on that by Richie Davidson at University of Wisconsin, by people in space the names. There's a great group in Sweden and a group in the Netherlands, and as well as in Baltimore, in the United States, both for kids, from 5 to 10, as well as for adolescents and teenagers. So my belief is that, yes, I think there's a good evidence base that it can be used. Of course, you have to introduce it in different ways. They're using more metaphors, using more movement, physical metaphors. So Richie does something really beautiful. If you're familiar with this kind of souvenir tchotchke or something called a snow globe, it's like a little, it's a clear plastic thing full of water, and then you shake it up, and it's usually like a little scenery, a pastoral scene of a building or something, and it's got snow in it. So Richie uses that as a metaphor for what is settling the mind, what is grounding. So it shakes up the snow globe and then lets it all sink down and come to. You can probably do that with sand as well. But yes, that is not my specialty. I do work with kids, and kids actually get it though as well, and they, particularly teenagers. I think I work more with teenagers than with small kids. I've tried to, and I've done some work, not a lot. Other people have done a lot more than me, but yes, I think they're, and I'm happy to share some references. Gina Bagley has a great book called Mindful Teens and a Whole Training Program, and also Mind Body Medicine with John Gordon has done work with families, including kids, and really interesting approach. This approach is somewhat different than mindfulness-based interventions, but it definitely includes mindfulness, and it's also a wonderful approach. And he's done it in a number of places, including Kosovo and Gaza, actually, 15 years ago. But yes, the answer is yes, and I'm happy to provide some book, some titles of books and empirical work if people are interested.
Дякуємо і дякуємо
Oh, thank
насправді
you
за
so
розмову.
much, and thank you for such a detailed answer for this question.
Дуже актуально
It's unfortunately really highly needed in Ukraine. The question, how do you work with the mindfulness techniques after the limb amputation? Like if somebody lost a leg or arm or all legs or all arms.
Yeah. That so I actually I thinking from experience, I actually did work with a couple people that had actually I'm going to share. I hope this doesn't come off the wrong way, but it was a very humorous experience. I was working in a prison in Michigan, in Jackson Prison, and we're doing the body scan, and I invited people to feel their toes, and one of the prisoners reached down. I didn't realize he was wearing a prosthetic leg. He pulled off his leg and then touched his toe, which was a joke on me. That's a really interesting question, in that I don't know of any active research on that. I do know a couple colleagues have done work with phantom limb pain. Greg Siegel again has been doing that because it's sort of a particular problem. It's one particular problem with loss. But I think it could. I'd like to think about that and maybe send an email back. I've not done it personally, but I do believe it can be helpful. Remains to be seen. The phantom limb pain, though, I think is fairly well documented. It's a particular exotic form of pain, and there, mindfulness approaches are helpful just like they are for any other form of neuropathic or neuroplastic pain. Because there, in that case, the pain is obviously not coming from a damaged tissue because the limb's not there. So it's literally coming from the brain. So yeah, it's a very good question. I don't have a good answer, but I'm going to speculate that I believe that there is some evidence out there, and I'd like to think about it and get back to the organizers, if that's okay. And yes, also to express, my sadness and appreciation of how difficult that situation is.
Oh, thank you so much. Thank you. And I'd just like to remind you for our participants that we will share with the approval from Dr. King his presentation. And if there's any additional materials that Dr. King can be used in your practice, we will also try to share it to you together with the announcement of the future webinars, and we will share all the materials that we have rights to. We still have 15 minutes, and so we have a lot of questions. So I would propose for us to move forward. So how can you notice that the mindfulness practice become an avoiding strategy? Can this be understood only from the words and the description of the client, that of his own experience, or are there any hints that you can notice that it's just an avoidance practice for them right now?
Yeah, that's a really interesting question. And so when I did mindfulness-based exposure therapy, when I ran those groups, as a group, we both did mindfulness practice as well as doing in vivo exposure. So not trauma exposure, but noticing, creating a hierarchy of avoided situations and then purposely moving into them, starting with about a 50%, on the subjective units of distress, et cetera, sort of standard behavior therapy. It's an interesting question. I mean, I don't know if there's any specific indicators that can be behaviorally observed, but I think talking about it, sort of, and asking people how are they doing, and this is the case of informal. There is actually something called the 3-minute breathing space we practice together. There's two forms of that. One is called the regular or the normal 3-minute breathing space, which we invite people to practice 3 or 4 times a day, and to record that, just check a box of how many times they did it, just to get used to it, to kind of build that skill. And there's another related practice called the responsive 3-minute breathing space. So in this case, we invite them, when they have upset, when the adversity rises, when they're For PTSD patients, I say very often it can be for anything. It can be for irritation. It can be for getting stuck in a line. It can be for people not doing what they said they were going to do. They don't respond to your email. Whatever the situation might be. The idea is to recognize when you're irritated. So it's similar in some ways to anger management techniques. Recognize, and then take 3 minutes out. Okay, moving in to noticing the body. The idea where it's different than avoidance is the invitation is to really not try to change it, to try to notice it. That's a difficult negotiation because people do want to change it. They do want to kind of settle themselves down. So it's really, I believe it's talking about it and asking people what happened. And that's part of the home practice review. We ask people, and that's also why the trauma or the mindfulness-based cognitive therapy groups are smaller, 8 to 12 people, 12 people absolute maximum, usually like about 8, as opposed to MBSR for general population, it could be like 20 or 30, because we really want to ask people, what are your experiences? How are you doing this? And when you're doing, so we'll try to get every person in the group to explain at least once how they're using the responsive breathing space. So it's an excellent question. And again, I'll sort of comb my memory and any data. But I think it mainly explaining and talking about it, asking people what their experience was like, and inviting them to stay present, inviting them to allow the experience, which is hard. I mean, we know this is why I call it exposure. The experience of terror, the experience of overwhelm, the experience of bereavement and sadness, and remembering a trauma. That's why we try to start also with easier things. We don't start with that. We start with when you get irritated because somebody cut you off in traffic. We also say don't do the mindfulness exercise in the car. You have to pull over. Once you get out later, then you do it. So I often use being stuck in a line. If you're at a store, you're trying to get something, or being late, or somebody not doing something that they said they were going to do. But again, an excellent question. I think these questions are fantastic because I don't have the answers for them. So that's really great. I will definitely think more. And but yeah, I think talking about it.
Дякуємо.
Well, thank you so much. The next question, to what extent in your experience it's important to have to stabilize them before and to develop self-soothing techniques before you put or introduce the mindfulness techniques into PTSD treatment?
Yeah, I think it's very important. That's why I kind of have two minds. So I do a standard mindfulness-based cognitive therapy group. I try for research purposes, we try to keep it, to adapt it to the least amount possible. So it was just some sort of a known intervention. So we don't try to do too many changes, but we do the self-soothing, the scaffolding, the window of tolerance, and the arriving, all in the first session. And then sometimes in the second session, we ask people, how was the body scan? In the mindfulness-based exposure therapy, which is admittedly a somewhat different approach, it was longer. So I spent the first 4 weeks really just doing psychoeducation about PTSD symptoms and physiology and relaxation and soothing. So from a clinical standpoint, I do think that at least, talking about this beforehand and actually maybe even introducing some self-soothing, the concept of window intolerance, and some relaxation even before the group starts is ideal. And then spending at least the first 2 sessions focusing on safety and regulating the nervous system. So I very much agree with the sentiment of that question. I think it is important.
Дякую. Наш таймінг
Thank you so much. Our timing allows us to have a few questions still, because we still have 9 minutes to go, but we want our speaker to have a bit of rest, and so we will make a small announcement just to catch the breath for the speaker. Dear participants, in the chat of the broadcast, what you can see is the link, which is the short anonymous survey, and we will kindly ask you to pass it. This is the survey conducted by the Coordination Center of Mental Health, who Kevin administers together with Texas University. The objective of this survey to decide what are the barriers in implementation of evidence practices in mental health. So we will be really grateful if you can give those like a few minutes to give the answers to. And I would just like to mention that this survey is oriented or targeted to experts or clinical specialties, psychiatrists, psychotherapists, clinical and medical psychologists, and also teachers in universities or higher educational facilities. Please point your attention. In our 8 minutes, we are getting back to questions because we think everybody catch their breath. The next question, unfortunately, caused by Ukrainian context, essentially, and the consequences of the full-scale invasion done by Russian Federation. So many people have vision loss, eyesight loss, or partial or complete. Do you know, or are you using like a separate methodology to working with people that has like vision impairment or full loss of eyesight? Did you have this experience? Because for a Ukrainian expert, this would be really important because we have lots of people with that. Thank you.
Yeah, thank you. I have a little bit of experience, and more a colleague of mine at the University of Michigan, David Fresco, and Dr. Tiran Jayasambara, who's so he works not with traumatic eyesight loss, but with macular degeneration and other sorts of neurodegenerative degenerative eye disease. Which is also kind of really horrible because people know that they're going to go blind. They're going to lose their vision within 6 months or so. So they've developed some mindfulness-based approaches for that, which I think will also lend itself to. I mean, I tend to think so that the beauty of group interventions are that they're efficient, they can be done with groups of people, and that there's support. I often like to have groups that have similar experiences. So first of all, I do think that, yes, it does make sense. I myself, although I can see, I'm experiencing low vision, so I can't drive anymore. So that's been a challenge for me, and a very minor challenge compared to what you're talking about. But yeah, it's an excellent question. Again, not having direct experience, but I do believe that the approach lends itself to that, because it really lends itself to to attending to whatever the experience is, whatever the challenge is, noticing the emotions, noticing the unhelpful thoughts. The difference between mindfulness-based cognitive therapy and sort of cognitive behavioral therapy is more an approach and attitude than it is in technique. It's a little bit. So cognitive behavioral therapy, as we all know, is focused on identifying cognitive distortions, refuting them, and coming up with a better, more accurate, more adaptive cognition. Mindfulness-based approaches also identify all sorts of thoughts, every thought. And the idea is recognizing that thoughts are thoughts, and that sometimes they're adaptive, sometimes they're maladaptive. So it's creating that space. And around, losing eyesight, there are probably so many thoughts and emotions associated with that. So yeah, I'm just conjecturing. This is conjecture. So I don't have direct experience other than the work that Dr. Jayasambara has been doing, which I think has been helpful. I also wanted to say something I forgot to put in. I had the slide and I forgot to put it in. But one of the challenges with mindfulness-based interventions is that the training is fairly intensive. And to be certified, I became certified in mindfulness-based cognitive therapy. It took me like 8 years and like $20,000 or something. It was very silly in some ways. But the training is fantastic. But I think it can become a barrier to being able to utilize. So I'm very interested professionally and scientifically in what is the right amount of training. what do people really need? Of course, we would all love to, to train all the time, but and have the best circumstances. But I'm really interested in what is the kind of appropriate amount that's most effective. And I do believe, I think there's something called a teacher training intensive, which is usually about 5 days, which is a pretty big investment. But I've been to a couple of those myself, and I've led some for my trainees.
Sorry, somebody's microphone was just on. Please continue.
Oh no, that's okay. That's all I wanted to say, and I will also send some materials on kind of where to get this type. If people are really interested in diving in deeper and getting sort of official training in mindfulness-based approaches, there are a number of institutes that do it. It costs money. They might give you a discount, I hope. And also, my group has also been doing some training. So if people are interested in that, I can certainly work. Would be interested as well in seeing how we might be able to do this on a free basis. I think, yeah. So next question. I guess we have 3 minutes left.
Так, ми встигаємо ще запитання.
We do have 1 or 2 questions depending on. In which cases do you think that the mindfulness can be not enough, and what is then the next step if the mindfulness is not enough?
Yeah. So I think in many cases, I mean, I look at mindfulness as sort of a mindfulness-based cognitive therapy, the standard 8-session groups, is particularly useful for people who started to do or contemplated doing trauma-focused work and then dropped out, or who didn't want to do it. What I think the mindfulness-based approach is really helpful for, and for some people it's enough. Some people, when I've seen, we have data, people, some people lose PTSD diagnosis. The majority of people don't. The effect size is about 0.8, and we got about a 50% remission rate, which means 50% people need more. What I think it's helpful for is helping to provide sort of an entree, a less arduous, more engaging entree into basic therapeutic skills. What a patient or somebody who's going to do psychotherapy needs. And I think having it, again, what we do is at the end, we have a one-on-one at the beginning, we have an 8-week class, and then we have an exit interview. And at that point, we do referrals. Then I either refer, most of the patients that I work with, I refer to cognitive processing therapy. But I think, trauma-focused cognitive behavioral therapy is also excellent. And for some people, I think prolonged exposure or EMDR is also helpful. So I think it's particularly helpful. The mindfulness-based approaches are particularly helpful for people who don't want to do these other treatments. And it helps them to kind of increase skills and to decrease avoidance. So, I mean, just a standardized, I don't know how commonly the PTSD checklist is used in Ukraine. It's, I think it was developed in Mississippi. It's a 20-item self-report measure. And so I just look at their PCL. And if it's above 35, talk to them about, hey, you've done that. You've taken the chance with me. You've done this group. It was hard. You did it. Are you ready for more? And here's what I would recommend. Or Tatiana, do you know? I see Tatiana there. Do you know do people use? How commonly is the PCL used? Or is there?
It's commonly used. Yeah, it's very commonly used. People are familiar with that.
Excellent. Yeah, so that would be what my go. I just look at their level of symptoms, and like I said, if they're 35 or more, I would be talking about. Or even if they're not, even if, I would then say, okay, you've done this, you've stepped out, you've really made this great effort, you've done this intervention. Here's more that you can do if you're willing. Oh, I think there was one more question, so I want to make sure I try to do that too.
У нас насправді таке запитання.
I mean, we have a lot of questions, but we have a question and a request. For you, can you share if you have advice and references on the lectures, books on mindfulness, or what are the reference, in your opinion, are the main basis or the background with which you can move on? And we can ask also the maybe you can share us with the lists, or what is your go-to list, what is your go-to library, and we can send it to all the participants together with the presentation.
Absolutely.
If you would be so kind.
I'm delighted to share the presentation. It's my honor that there's interest. And yeah, I can share. So my go-to, one of them is by Zindel Siegel. Can't find it right now. Somewhere in my bookshelf, called Mindfulness-Based Cognitive Therapy for Depression Relapse Prevention. I'll share that. As I said, and he's really an I mean, Zindel and John Teasdale and Mark Williams are just outstanding. I mean, really world-class therapists, and they're excellent writers. That's not focused on PTSD, but I think to get the basic training, and it's manualized. It's a really good book. It might cost $100 too, unfortunately, because they want to get paid. But there's also, I will also look. I've written a couple chapters specifically focusing on mind adaptations for PTSD. Trish Magyari, and there's a book by David Treeleven. I would also look to see if there's additional resources that are free that can be provided. But yeah, yes, very much, very happy to do that.
Дякуємо.
Well, thank you so much. Thank you kindly. And both for your time and for the knowledge and for honesty and for how deeply we felt you being present here for us. For us, the professional community, this is so tremendously valuable. So thank you so much. And in reality, also, thank you to our participants. And because even it's late in Ukraine, right? It's almost 9 o'clock in Ukraine, right? In the evening. So it's still, we have so many of you. There have been more, 1,500, so 1,500 on different platform, on the Coordination Center webpage, in the YouTube channel, in Facebook. And so people who were not able to join will be able to watch the recording of our talk, which can be done on YouTube, and to pick this knowledge with you to go forward. Thank you so, so much to our dear speaker, to our participants. See you next time, and see you soon. Thank you so much, and have a peaceful evening and a good night. If you want to have any parting words, this is the time, I guess.